I wanted to kick off by asking you about the announcements, obviously wildly relevant to the hospitality, from 2 meters to 1 meter plus. And so let's start with the UK and get your read on this necessary, difficult, wildly complicated balancing act of seeking to curb a pandemic, but also achieve the kind of economic goals that are equally important in a society. What's your judgment on the policy announcements that have been made? Where do you think they're getting it right? Where do you remain concerned?
Yeah, thanks, Paul. So, as I'm sure many of you saw yesterday, a big, series of announcements, which effectively ends the lockdown for all intents and purposes, right? And most of this will be implemented on the 4th of July, interestingly, so a couple of weeks away. But a number of things are opening up. Just about all businesses, including restaurants and pubs, including some parts of the hospitality sector, including hotels and Airbnbs and things like that, outdoor exercise spaces, some things, churches and houses of worship, with some limitations. A few things are still remaining closed. Hair salons are opening, nail salons are staying closed, indoor gymnasiums are still closed. And then, as you mentioned, the 2 meter kind of social distancing rule has now been relaxed to what they called 1 meter plus. And the explanation is 2 meters when you can, but when you can't, be more careful. Unless you can be closer to people, but please wear a mask and sort of use common sense. It would have been better if they said stick with 2 meters and then wear a mask just in case. If you were to sort of pull out a measuring tape and measure yourself 1 meter away from a family member in your household, it's sort of effectively personal space, right? It's not very far apart, and certainly will increase the risk of transmission should one of those 2 people be infected. So overall, I guess my take on this is, there are aspects of it that are thoughtful and careful in terms of how they're opening certain things back up. At least this time it came with some consultation, and that they released a series of kind of specific guidelines for different sectors at the same time they made the announcement. So it gives these different industries time to kind of plan for what that change is. So that's, I guess, on the positive side, there's a little bit more kind of transparency and consistency there. However, and it's a big however, it's a big gamble. It's a really risky move to make right now. And the main reason for that is that our transmission levels in this country remain not low. Maybe it's not fair to say high, but too high to be opening up like this, right? We have about 1,000 reported cases per day. In reality, it's probably 2 to 3 to 4,000 cases per day. So we're kind of looking at 25,000 cases a week, close to 1,000 deaths per week. This is not trivial amount of circulation of this virus as we speak, right? And a lot of that is virus that's not being detected by testing. 2 in 3 cases are probably still going undiagnosed. Therefore, even if you had a contact tracer, they're not going to be able to follow that up and break that chain of transmission. So what we're doing is at a baseline level of transmission, which is not as low as it needs to be, we're now doing a whole bunch of things that are going to increase the R rate and increase the risk of transmission. So basically, from what I can gather, the overwhelming scientific consensus, including on SAGE, as well as the independent SAGE, is that from a purely public health standpoint, this is risky. And so it's a decision that's being taken really for economic reasons, I think, under a lot of pressure, because I think there are a lot of businesses that are saying, look, we can't go on like this any longer. This is existential. And so it's kind of a rescue mission to save businesses and save the economy from tanking further. But in doing so, that kind of short-term play puts us, I believe, at a significantly greater long-term risk of this flaring back up, particularly because we don't have great surveillance and early detection systems that can break those chains of transmission and allow us to take what may start as a localized outbreak in one community, one care home, one meat processing plant, and nipping it in the bud before it starts to spread around. So this increases the chances that we see another wave. If not in the real short term, then as we get later into the summer, closer to flu season in the winter.
Let me ask a question about a combination of 2 things. firstly, just empirically, is it roughly half of all deaths occurred in care homes or there or thereabouts? Or what, just remind me the number.
I haven't seen the most up to date, but it was on the order of about 40%
Okay.
of the sort of reported death toll occurring in care homes. That was as of a few weeks ago. Now we're not as precise for the kind of the excess deaths, the other ones that are attributed to COVID but haven't been confirmed. But it's a shockingly high number of our sort of elderly and most vulnerable members of our communities who perished thus far.
Okay. So if we have determined a series of measures which we could implement and stick to, which are more targeted at the people who are most vulnerable, and the kind of easing of the lockdown then applied to people who are less vulnerable, point one. And secondly, in what we've achieved thus far on treatment, let's leave aside vaccine, is there an argument to say, even if the R rate increases because of sort of protection and self-isolation of the most vulnerable and the continued necessity and willingness of that group to do so, plus some kinds of treatment, we discussed some of them last week, which can get people, save people's lives when they get into real trouble, and cocktail therapies and a combination of other things, that in fact, that the lockdown now, although the R might increase, the mortality rate actually will not correlate with the increase in the way that transmission will, if poorly formulated question, but I think you know where I'm going.
Yeah, I think there's something to that. So parts of it I agree with, parts of it I think are complicated. So certainly we know that in congregate settings where you have a lot of people in an institutionalized closed space, that's really high risk for transmission. You compound that with those people happen to be the most high risk, in this case, very elderly, tinderbox, right? So we can and should be doing all we can and giving all priority to putting safety measures in place, PPE for the care home workers, insane amounts of testing, et cetera, and careful measures to protect, those places. Absolutely. There are a lot of other folks, as you know, around the country who have been shielding because they also fall under various categories of so-called vulnerability, either by age or by medical comorbidities. It's hard to continue that forever. And in fact, that also is going to end. And it's hard to shield those people because most of them live with other people who are all going to be out and about doing stuff. So once people start going back to work and going out to restaurants and bars and things like that, you can't you can't be isolated from those folks forever. So there's no way that you can really effectively have shielding from all the vulnerable people and be open at the same time effectively. There's going to be contamination of that. The other part of your question, I think, is a really important one, that we've learned a lot about how to treat the disease in ways that should hopefully make the mortality rates lower in well-developed settings where there's robust health systems like the UK. So that's not only things like dexamethasone, the steroid, which in certain settings, people needing oxygen or ventilators has significantly reduced mortality. The antiviral remdesivir, which plays a part. There's some other stuff we're finding that anticoagulants, that blood clotting is a big part of what makes people really sick. And so there's some biomarker testing you can do, and that putting people on blood thinners who are hospitalized can help. We've learned a ton about the way that you ventilate patients in ICUs. All of these things together mean that hopefully, even if we were to see a surge in cases, that mortality would be lower because we can do a lot better taking care of those folks. One thing we've also seen in some places where there's been kind of a resurgence, the US would be the example that comes to mind, is that I don't want to call it a second wave because it's confusing and it's really just still a first wave in the US, but the places it's surging right now, it's surging largely in the young adult population. And that's just because they're the ones who are out and about, and there seems to be a lot of transmission and places where young people are hanging out. That's a bad thing because it's causing massive spread, and that may trickle out into other age demographics. But if you take sort of the situation in like Lombardy in Italy, where it's a really elderly population, if they're the ones who are getting all the COVID, you're going to see a lot of deaths. In a younger skewing population, that may help you a little bit. But the reality is we know that this virus is is fast, and we don't want to let, sort of the genie out of the bottle because it's really hard to put it back in.
So let's stick with we're going to pivot back across the Atlantic, but let's stick with the UK for a moment. Before we went live, we were talking about the vanishing without trace of the track and trace. And if you called early that the care home deaths were a scandal and a disgrace, this surely has to be up there as a kind of totemic monument to incompetence in a country which has one of the most developed tech sectors in the world. Why on earth are we incapable of tracking and tracing?
Yeah, it's kind of insane, right? It's hard work, but it's not rocket science, right? It's like it takes a lot of effort and there's some complexity, but we can put a man on the moon, or person on the moon, I should say. We should be able to do this, right? So quickly, if you go back early on, there were some capabilities in local public health England, organizations to do this. This was abandoned back in early March. So quickly it was determined, actually we already have so many cases that it's going to be impossible to keep up. So let's just forget it. And they lied at the time and said that it wasn't necessary or it wasn't indicated. What they really meant was that they didn't have the capacity any longer and it wouldn't help that much. So they abandoned it in the same way that they abandoned testing largely in, those fateful sort of early March decisions. And then they just kind of left that aside for a lot of the lockdown, and then started thinking about how you're going to open up and what's going to be needed. And of course, a part of that is testing and tracing and things like that. So when we should have been using these many, many weeks, these 12 or so weeks of immense personal and economic sacrifice we were all making to flatten the curve and to nip this thing in the bud, to prepare for what happened next, we were really slow to start. And then when we did, it was, let's outsource this to a private contractor. Sure, they're big and they have the capability to mobilize lots of contractors quickly, even though they have a terrible track record of fraud and corruption, among other things. And the same thing was done with the contact tracing app, where it was developed in a kind of very centralized way. And the idea was, we're going to build our own, as opposed to seeing what's already out there and seeing whether we could leverage existing technology and adapt it for our own settings, basically. And the obvious one is Apple and Google, who never worked together on anything, collaborated to develop a platform that works with their phones, which is all phones practically, right? Android and iOS, to function and get through their various security firewalls and things like that. So about 11 million pounds was spent and months of work to develop this app that didn't work. They trialed on the Isle of Wight and it just absolutely failed. And finally last week announced that they were scrapping it and we're now going to move over to trying to adapt a version of the Apple Google app, which has been rolled out elsewhere. That's not to say everywhere else has been perfect. France is having some challenges with theirs, et cetera, et cetera. But we've seen as a twin failure of the technology side of contact tracing and the human side of contact tracing, right? You've all read the reports about people who are contact tracers who said, I had no training, or I had one webinar and I'm getting underpaid. And by the way, I haven't actually talked to anybody. I haven't given anyone to trace yet. So I'm just watching Netflix all day long. Most of the contact tracing that's being done is actually being done by local PHE. And that's appropriate because they're in their communities and they know their communities. So what we should have done is say, let's build on our existing local infrastructure in councils, basically through local PHEs, and then let's embed this existing technology and then build a system from the bottom up. So where we're at now is that we're maybe practically starting from scratch on the tech side, and the contact tracer world-beating army is really weak, right? So, we know that we're missing 2 out of 3 cases aren't getting diagnosed because we're not testing enough. And of those that we do diagnose, at least a third of cases so far are not having any contact tracing kind of follow-up. So the sum total of all of this is our defense mechanism against the second wave, and it's not fit for purpose yet. And that's the other piece of what makes this reopening, I think, more risky.
So from the frying pan to the fire, I listened to Anthony Fauci yesterday, give his pronouncements on his concern. The US seems to be surging in ways that are deeply, deeply alarming. And the current constitutional and political situation with a tussle between the federal government and the states means that not only is it not really capable of being addressed, and that there is never going to be a lack of mobility between US states, but also you have a president who is actually pushing actively in the other direction, which is, I think, producing the results that we're seeing. How do you see, if you close your eyes and paint a picture of the US in November, December, what's the picture that you think is most likely to obtain?
It's going to get worse in the short term. So let's start there, right? So we talked about kind of the origins of this resurgence a little bit last week. Since then, we've seen, double, triple digit increases. So in the states that have really come roaring out, Arizona, Texas, Florida, we're talking about 100% increase in cases over a week or two. Hospitals already filling up. We're finally just now seeing in a couple of places like the governor of Texas urging people to stay home, not making a mandatory sheltering in place order, but it's getting there. Yesterday was the third highest daily case total the US has seen since this pandemic started. And if you look at the trend lines, by the end of this week, we're going to be at 7-day averages that are the highest the US has seen throughout this. So worse than when it was at its worst back in April. So it's raging out of control in lots of places. Oh, we've lost the panic button.
that is to me the perfect metaphor. Things are so bad, the panic button.
We don't even have, there's nothing. The help is not on the way. So we've seen these dramatic increases, and up until really today, nothing has even been done to slow it down, right? This all came because of hasty, inconsistent reopening that was happening at a time when cases were still increasing in lots of places. So we know it's going to get a lot worse, because even if we started to do something today, it'll be weeks before you start to see that bending of the curve again. And again, I think the genie's way out of the bottle here. This is different than back in March and April, when you had a really significant outbreak in New York and surrounding areas, and then in Seattle and surrounding areas, in Northern California, a few other places, Louisiana, Chicago to an extent. This is a wide swath of the country which is raging uncontrolled. And as you said, at the federal level, nothing is being done. So you mentioned the kind of constitutional local versus federal thing. It's kind of a, I don't think it's correct to say that because of that conflict, it's hard to manage this, right? Lots of countries have decentralized governance. Germany does, Spain does. Lots of places have struggled between different priorities at the federal and local or state levels, and they figured it out. Here, there's been a total abdication of responsibility at the federal level. And a long time ago, they said, states figure it out. They gave some guidelines, but then abandoned their own guidelines. They've totally left this up to states and localities to figure it out. So it's that the U.S. government's not doing its job, and it's costing a lot of lives. That's I think the bottom line. As you say, the president is actively making things worse, right? By talking about or possibly even asking testing to slow down, which is astonishing, and then doing things like holding the rallies and things like that. So it's not just incompetent, but malignant leadership. I don't know whether, now that things are hitting in kind of red states and in Trump country, whether as things get bad and because of that suffering, that will change the calculus a little bit, because this has been so politicized, right? Like wearing a mask is a sign of, to some, of like disrespecting the president. He said that, or of weakness or whatever. Maybe that will change now, right? What was different is that when this was affecting mostly liberal big cities on the coasts, it was easier if you were sitting in the middle of the country to say, this isn't our problem. It's not going to hurt us. They're all overreacting, whatever. Maybe the one little dose of optimism is now that everyone's getting hurt. Maybe it'll snap us out of this funk where everything is divided, and from the ground up, we'll build something. But I mean, we're going to be looking at we're going to be looking at staggering numbers for, probably for months to come. Unfortunately, I'm just not optimistic right now. And it's hard to see that changing as long as the current occupant of the White House is there, unfortunately.
Well,
interestingly, the president of Brazil was ordered by a judge to wear a mask. I wish a judge in America could do that.
That's just astonishing as well. So let's pivot to, your daily, your global roundup of science, vaccine treatment. Maybe there's some, I know there's some setbacks, some disappointing news, but also some good ones. So tell us what you got to give.
Sure. On the vaccine front, the so-called Oxford vaccine called ChAdOx1, which has been in trials here, couple of developments, right? They're moving and starting a couple of other big trials in Brazil and South Africa with tens of thousands of participants, which is great. And these are places where there's a lot of circulating virus. And that's a good thing from a research standpoint, because the more people you have getting infected in the population, the easier it's going to be to determine a difference between the vaccine protecting one group versus the control group. So it's perverse, but it's really hard to prove that a vaccine works when you don't have a lot of a disease, right? So that's helpful. And it will be the first vaccine trial, COVID vaccine trial on the African continent. And so engaging the robust and underappreciated scientific community there in this fight, I think, is also going to be really useful over the long term. There were also some study results that you pointed out to me, Paul, another animal study on the same Oxford vaccine that found that in pigs, that they developed what looked like a robust neutralizing antibody response to the same vaccine. And pigs are biologically and genetically very similar to humans in lots of ways. So like the rhesus macaques in the other study, it's a useful model because they're analogous to humans in many ways. So another little bit of good news about the potential clinical efficacy of that vaccine. I don't know whether the pigs got infected or not. Remember, with the rhesus macaques, they actually got infected even if they were vaccinated. They just didn't get sick. And that's a little bit of a curious finding that I don't love, but we'll see what it means as we learn more. But the other finding that I noted as we were talking about this is that the response was much better with 2 vaccines, like 2 doses of the vaccine versus 1, which is unfortunate because 1 would be a lot easier than 2. So we'll see. As you know, there's some vaccines where you need 2 or sometimes even 3 in some succession to get the kind of response that you need. So some mixed but mostly good news there. The big US vaccine started by the company Moderna and backed by the US government announced they're planning to start a phase 3 trial, the last big phase, in July if everything continues on the same glide path. So that one is also continuing apace. And so those 2 kind of lead candidates are good. Other stuff in the science this week, a little bit of less good news. There's another paper actually sent by one of my Twitter pals who watches this webinar, Jeremy, that a small Chinese study that looked at folks who had been infected, both who were symptomatic and asymptomatic. And in both cases, they had antibody responses, but they dramatically tailed off within 2 to 3 months after infection, about a 70% decline in the level of antibodies by about 3 months. We don't know what that means. A decrease in these particular antibodies doesn't necessarily mean a decrease in immunity, but it certainly might. So it's just a kind of disconcerting little nugget of data that suggests that immunity may not last for a long time, which is true of lots of other coronaviruses. That has implications for vaccines. It has implications for long-term population immunity. I wouldn't put too much into that one small study of about 70 something people, but obviously we'd like to see something different. On the treatment side, the data from the dexamethasone study came out and it hasn't been peer reviewed, but as robust as was announced. And so that remains, I feel a little more confident than I did a week ago that that's legitimately pretty good news. And we're now seeing that in widespread use. That could actually be a life-saving intervention that's available everywhere in the world. So that's great. And there continues to be, I think, a more sophisticated understanding of the different processes that make people really sick. So you have these kinds of different types of tools in your arsenal now. immunomodulators like dexamethasone, antivirals like remdesivir, the blood thinning medicines that I mentioned, oxygenation therapy. It's now giving clinicians a much stronger understanding of how to keep people alive. So that's, I mean, that's huge, and could be, as we approach kind of the winter months. That doesn't necessarily, maybe it lessens the risk some of the kind of NHS capacity, but certainly I think makes us feel more confident that this may become a less deadly disease than it has been, at least in wealthy countries.
Let me ask you a wrap-up question. To the extent that 3 or 4 months ago, we thought of this as a scary disease that for a group of people who got very sick, it could, it has a kind of terrifying mortality rate. And now we have these combinations of treatments, both actually the treatments and the medications and all the clinical things that you've just referred to. Is there another disease out there that it's closer to that we should start placing in our brain as a result of this progress that has been made that makes us think of it as less scary?
Off the top of my head, I don't know. And I don't want people not to be scared. And actually,
right.
one caveat, let me insert an important caveat to what I just said, right? Which is that the consequences of this disease are not only mortality, but we also have to think about morbidity, right? And so the more time goes on, the more evidence we see of this. And if any of you have had this disease or know someone who has, it affects almost every organ system in the body. So we see tremendous lung damage, we see heart and blood vessel damage, we see neurologic damage, people who are taking months to recover and get back to a baseline level of energy, folks who are having concentration problems, anxiety type symptoms, all kinds of things, who are not getting back to normal. We don't have a good understanding of how to deal with a lot of that stuff, how to prevent it or how to treat it. So the big caveat is we could save more lives, but there actually still could be a significant amount of morbidity, suffering, loss of productivity as a result of this disease as well. So, so it's not just about saving lives. And that's something that we always need to keep in mind, and that for those of us who feel young and invincible should keep in mind too, because it's a miserable disease. So I don't know of a great analog, and it's not a perfect analogy, but if you think about, HIV at a certain point in time, when it went from a disease that would, it's different because HIV is a disease that's nearly universally lethal at some point. It may be years and years and years, but when it turned from a disease that was extremely deadly to one that could be a manageable chronic disease, albeit with all kinds of consequences, that began to sort of shift the landscape. And it took years, obviously, before those treatments were available to everyone who needed it. There's maybe something in that there. I can't think of another great parallel. And I would encourage everyone to continue to be respectful. I don't want to say scared. Be respectful of the power of this virus and its ability to surprise and humble us. And that's why we should remain really cautious. Even as July 4th hits and all the pubs open on a hot, sunny summer Saturday, frightening as that is.
And I think that is a really, really important note to end on, because I think the people who I know, and even in our own team who've had it, who continue to have high blood pressure and a whole range of very strange and troubling symptoms. So even as we make these advances, I think respecting and being cautious about something that is still a very, very serious disease is, I think, a good note to end on, even as we begin to open up. Peter, as always, thank you so much. For those of you watching live, thank you. And for those of you who tune in afterwards, the many of you, thanks so much for watching, and stay safe and stay well.